A very good morning to all of you. Once again, welcome to the teaching class of Department of Urology, Savai Mansingh Medical College, Jaipur. Today, we have a talk on embryology of the genitourinary system, and this will be presented by our resident, Dr. Mohd.Faisal, and will be moderated by our faculty, Dr. Somendra Bansal. So I would request Dr. Mohd.Faisal to start his presentation.
Good morning, respected teachers. Myself, Dr. Mohd.Faisal. I'm here to present a seminar on the topic of embryology of genitourinary tract, and my moderator is Dr. Somendra Bansal, sir. The genitourinary system developed from the intermediate mesoderm derived from the dorsal body wall of the embryo. The urinary system develops before the genital system. At the end of the third week, internal mesoderm differentiates into paraxial mesoderm, intermediate mesoderm, lateral plate mesoderm. The paraxial mesoderm forms skull and vertebra. Intermediate mesoderm forms the urogenital system, and lateral plate mesoderm forms the body wall. This is the cross section of the third week embryo, showing the paraxial mesoderm, intermediate mesoderm, and lateral plate mesoderm arranged in medial to lateral direction. A longitudinal elevation of the mesoderm, the urogenital ridge forms on each side of the dorsal aorta. The part of urogenital ridge giving rise to urinary system is nephrogenic cord, and the part giving rise to genital system is the gonadal ridge. The gene WT1, SF1, and DAX1 gene is responsible for the formation of urogenital ridge. In human embryo, the kidney develop in three successive sets. The first one is pronephros, followed by mesonephros and metanephros. Embryologically, all three kidney develop from the intermediate mesoderm. The pronephros appears early in the fourth week, which is usually non-functional, and very soon they degenerate. The mesonephros appears late in the fourth week, caudal to the pronephros, and it is function as an interim kidney for approximately 4 weeks until the permanent kidney develops and start functioning. The mesonephric duct first appears at the 24th day. Distal end fuses with the cloaca by the 28th day, and the mesonephros degenerate towards the end of first trimester. This is showing the fifth week embryo with arrangement of pronephros, mesonephros, and metanephros from cranial to caudal direction. And the distal end of the mesonephric duct gives a out pouching of ureteric bud, and finally it attached to the cloaca. As shown in this picture, the duct first appears at the 24th day, and up to the 25th and 26th day, as mesonephros start developing, pronephros starts degenerating. Metanephros, it is the primordia of the definitive kidney. It begins to develop at the fifth week and become functional approximately 4 weeks later. The permanent kidney develops from two sources. The first one is ureteric bud, and the other one is metanephrogenic blastema or metanephric mesenchyme. The ureteric bud sprouts from the distal portion of the mesonephric duct and comes in contact with the condensing blastema of metanephric mesenchyme at about 28th day. The second image shows the successive stages in the development of the ureteric bud from 5th to 8th week, which finally give rise to the collecting system, including collecting tubule, minor and major calyces, renal pelvis, and ureter. The ureteric bud and metanephric mesenchyme exert a reciprocal inductive effect towards each other when come into contact, and the red GDNF GFR alpha 1 pathway play a crucial role in this inductive effect. As discussed, GDN factor is secreted from the metanephric mesenchyme and activates the red receptor, which is a tyrosine kinase receptor present in the ureteric bud epithelium. The expression and localization of the GDN factor are positively regulated by EYA1 and PAX2 gene, and negatively regulated by the FOXC1 and FOXC2 transcription factor. The cranial part of the ureteric bud undergoes repetitive branching, which differentiates into the collecting tubule of the metanephros. The first 4 generation of the tubule enlarges and polyses to become major calyces, and the next 4 generation forms the minor calyces. By 20 to 22 week, ureteric bud branching completed, and the stalk of the ureteric bud finally gives rise to the ureter. This picture shows the dichotomous branching of the ureteric bud at their cranial end and finally forms the collecting system. The nephros, that is glomerulus, proximal tubule, loop of Henle, and distal tubule derived from the metanephric mesenchyme, and the collecting system, that is collecting duct, calyces, pelvis, and ureter derived from the ureteric bud. In human embryo, nephrogenesis is completed before the birth at around 32 to 34 week of gestation. However, renal maturation continued to take place even after birth. This picture shows the condensation of the metanephrotic mesenchyme in the pink color, which finally forms the Bowman's capsule, proximal convoluted tubule, loop family, and distal convoluted tubule, and the ureteric bud in the purple, which finally gives rise to the collecting system. Next topic is renal ascent. Initially, the primordial of the permanent kidney lie close to each other in the pelvis, just ventral to the sacrum. Between the 6th to 9th week, the kidney ascend to a lumbar side just below the renal gland. Initially, the hilum of the each kidney faces ventrally. However, as the kidney ascends, they rotate medially almost 90 degree and attain the position of hyla anteromedially in finally. Renal ectopia. When the kidney fails to ascend properly, its location becomes ectopic. If it ascends fail completely, it remains as a pelvic kidney, and pelvic kidney are so close to each other, they usually fail to form a discoid or pancake kidney. When one kidney is located on the side opposite from that in which its ureter insert, it forms the crossed ectopia. 90% of the crossed ectopic kidney are fused to their ipsilateral mate, and their normal curvature is based on the position of the crossed ectopic kidney. In some condition, the crossed renal ectopia occurs without fusion. It can be solitary kidney with crossed ectopia or bilateral crossed renal ectopia also present. Many theories has been postulated like influence of genetic factor, teratogenic factor, or malalignment and abnormal rotation of the caudal end of the embryo that will lead to aberrant development of the metanephric blastema and ureteric bud during the 4th to 8th week of gestation. So both the kidney could not achieve their normal position, but exact cause of crossed ectopia is still not known. The next one is horseshoe kidney. In 0.2% of the population, the poles of the kidney are fused. Usually it is the inferior pole that fuses. Normal ascent of the fused kidney is prevented because they are held down by the root of the inferior mesenteric artery. It occurs because sometimes the kidney are pushed so close together during their passage through the arterial fork, which is formed by the umbilical artery, that their lower end get fused. Normally, horseshoe kidney are asymptomatic, and approximately 7% of the patient with the Turner syndrome have horseshoe kidney. This image shows the normal and abnormal ascent of the kidney. As shown in the picture 3, it may be possible that one kidney ascends normal and second one becomes the second one fails to ascend. Renal agenesis. The renal agenesis results when the ureteric bud do not develop at all, or the primordia of the ureteric bud of ureter degenerate, or failure of the ureteric bud to penetrate the metanephrotic blastema results in failure of the kidney development. It can be unilateral or bilateral. Unilateral renal agency is more common. The incidence is 1 in 1,000 birth. Males are affected more, and it is the left kidney which is usually absent. Zinner syndrome is a developmental anomaly of the renal tract. This condition is defined by the triad of unilateral renal agenesis, ipsilateral seminal vesicle cyst, and ipsilateral ejaculated duct obstruction. The syndrome is due to malformation of the mesonephric duct during the embryogenesis. On the coronal section of the CT shows left side renal agenesis with a hypodense cystic lesion protruding into the UV lumen, suggestive of ipsilateral seminal vesicle cyst. The incidence of bilateral renal agencies is 1 in 3,000 birth. It causes, due to absence of the both kidney, it causes oligohydramnios that allow the uterine wall to compress the fetus. As a result, there occurs Potter's syndrome. The clinical features of the Potter syndrome are deformed limb, wrinkling of the skin, and abnormal facial appearance. The malrotated kidney. If a kidney fails to rotate, the hilum faces anteriorly, that is the fetal position of the hilum. If hilum faces posteriorly, rotation of the kidney proceeded too far, and if it faces laterally, lateral instead of medial rotation has occurred. Bladder and ureter development. The ureterogenital sinus is divided into 3 parts: the vesical part, pelvic part, and the phallic part. The vesical parts form the urinary bladder. The pelvic part forms the proximal urethra male and entire male, and the phallic part goes towards the genital tubercle, which finally forms the penis and clitoris in male and female respectively. The image shows the arrangement of the vesical part, pelvic part, and phallic part, and the continuation of the allantois with the vesical part. The bladder developed mainly from the vesical part of the urogenital sinus, but its trigone is derived from the caudal end of the mesonephric duct. The right and left common mesonephric duct fuses in the midline and triangular area forming the primitive bone. Initially, the blood is composed with the allantois. The allantois soon constrict and become the thick fibrous cord that is urachus. And in adult, the urachus is represented by median umbilical ligament. There are some congenital anomaly of the urachus. It can present as urachal sinus, urachal fistula, and urachal cyst. If the lumen persists in the upper part only close to the umbilicus, the condition is called urachal sinus. If the lumen persists through the entire length, the condition is called urachal fistula. If only a small part of the urachus remains patent, the condition is called urachal cyst. The duration of results from abnormal division of the ureteric bud. There can be incomplete or complete division of the ureteric bud. In case of incomplete division of the metanephrogenic diverticulum or ureteric bud, results in a divided kidney with a bifid ureter. In case of complete division of the ureteric bud, it results in a double kidney with a bifid ureter or a double ureter. The condition of supernumerary develops when a second bud branching from the initial ureteric appears as a necessary first step. There are also other conditions like double renal pelvis, bifid ureter, and double ureter. Double renal pelvis occurs due to premature division of the ureteric bud near its termination. And bifid ureter, as like in double pelvis, this condition also occurs due to premature division of the ureteric bud towards its cranial end. And double ureter, it occurs due to early division of the ureteric bud as it arises from the mesonephric duct. Ectopic ureter. Any ureter that does not enter the trigone is considered ectopic, either it is single or duplex. Ectopic ureter can arise due to abnormal timing or abnormal location of the ectopic ureter can arise due to abnormal timing or abnormal location of the primary ureteral budding from the mesonephric duct. In a duplex system, the ectopic ureter is inevitably the upper pole ureter due to its budding from the mesonephric duct later than the lower pole ureter. As shown in the figure, Wigert-Meyer rule says that the ectopic ureter or ureterocele associated with the upper pole is caudal and medial to the lower pole ureteric orifice. Ureterocele formation results by failure of rupture of distal membrane of the ureteral orifice. This one is retrocaval ureter. The right ureter may pass posterior to the inferior vena cava before hooking medially. This abnormality is a vascular rather than a ureteral developmental anomaly in which subcardinal vein persists in forming the IVC rather than the supracardinal vein. For this reason, the term preureteral inferior vena cava has been favored in some texts. This picture shows when a supracardinal vein forms the IVC, the position of ureter is normal, that is anterior to the IVC. If subcardinal vein forms the IVC, the ureter becomes retrocaval. Genital and reproductive development. During the 5th week, primordial germ cell migrate to form the yolk sac to establish the gonadal ridge along the posterior abdominal wall of the embryo. During the 5th week, the genital is formed with the posterior abdominal wall just medial to the developing mesonephros. The primordial germ cell induced the coelomic epithelial cell lining of the peritoneal cavity and the cell of the mesonephros to proliferate and form the primitive sex cord. During the 6th week, the paramesonephric duct developed lateral to the mesonephros. The caudal tip of the paramesonephric duct fuses with each other before coming in contact with the urogenital sinus. Under that is a sex determining region of the Y chromosome. In the medullary region of the primitive sex cord begin to differentiate into the Sertoli cell, while the cells of the cortical sex cord degenerates. Sertoli cell secretes a Mullerian-emetic substance, which is a glycoprotein, which causes the paramesonephric duct to regress rapidly between the 8th to 10th week. In female embryo, as MIS is absent, therefore the Mullerian duct do not regress and give rise to fallopian tube, uterus, and upper 2/3 of the vagina. Mullerian duct remaining in the male forms the appendix of the testis and prostatic utricle. By the 9th and 10th week, the Leydig cell differentiate under the effect of the SRY gene and responsible for the formation of testosterone. By the 8th and 12th week, testosterone stimulates Wolffian duct to transform into the vas deferens. The cranial portion of the nephric duct degenerates, leaving a small remnant that is called appendix of the epididymis, and mesonephric duct adjacent to the presumptive testis differentiate into the epididymis. Prostate and seminal vesicle development. During the 10th week, the seminal vesicle sprouts from the distal mesonephric duct in response to testosterone. Prostate and bulbourethral gland develop from the urethra in urogenital sinus in response to dihydrotestosterone. The remnant of the mesonephric duct in males form appendix of the epididymis, in females form Gardner 6 along with epiphoron and parophoron. This image shows the fate of urogenital sinus mesonephric duct and paramesonephric duct. As shown, mesonephric duct finally forms the ureter, seminal vesicle, verbourethral gland, duct of epididymis, ductus deferens, and small remnant part at the cranial end to form appendix of epididymis. As discussed in female genitalia, in the absence of Mullerian-inhibiting substances and androgen, the Wolffian duct degenerate and the Mullerian duct give rise to fallopian tubes, uterus, and upper two-thirds of the vagina. During the 10th week, the paramesonephric duct fuses at their caudal end, establish a common channel, and come into contact with the thickened portion of the posterior urogenital sinus called the sinovaginal bulb. This is followed by development of the vaginal plate, which elongates between the 3rd to 5th month and become canalized to form inferior vaginal lumen. An endodermal membrane temporarily separates the vaginal lumen from the cavity of the definitive urogenital sinus, that is vaginal hymen. There are some congenital anomalies of the uterine development. It can be double uterus with double vagina, double uterus with single vagina, bicornuate uterus, or unicornuate uterus. The double uterus with double vagina occurs due to complete lack of fusion of paramesonephric duct and sinovaginal bulb. The condition of double uterus with single vagina occurs when paramesonephric duct fails to fuse but lie close to each other. As a result, the uterus is entirely double and the vaginal plate formed in relation to each duct fuses with each other to form a single vagina. The condition of bicornuate uterus develops when the paramesonephric duct fuses with each other only in their lower part, while remain separate in their upper part, thus giving rise to two horns of the uterus. The condition of unicornuate uterus occurs when one paranephric duct completely degenerates so that only one horn of the uterus with one fallopian tube persists. The image shows the double uterus with double vagina, double uterus with single vagina, bicornuate uterus, and the unicornuate uterus, respectively. The development of the external genitalia. Up to the 7th week, the external genitalia are similar in the both sexes. Cloacal membrane is bilayered structure. During the subsequent development, this bilayered cloacal membrane retracts into the perineum as a result of cranial and medial migration of the mesodermal cell into the anterior body wall between the ectoderm and endoderm layer of the cloacal membrane. This mesenchymal migration leads to closure of the inferior part of the anterior abdominal wall. The migrating mesodermal cells responsible for the formation of musculature of the medial portion of the anterior abdominal wall, the mesenchymal portion of the anterior bladder wall, the pubic symphysis, and the rudiments of the external genitalia. Failure of migration of these mesodermal cells into the midline results in the condition of bladder extrophy. Early in the 5th week, a pair of swelling called the cloacal fold develop on either side of the cloacal membrane. These folds meet just anterior to the cloacal membrane to form a midline swelling called genital tubercle. During the cloacal division into the anterior urogenital sinus and the posterior anorectal canal, the portion of the cloacal fold flanking the opening of urogenital sinus becomes the urogenital fold, which is responsible for the formation of penile urethra and shaft of the penis in male and remains unfused to form the labia minora in female. And the portion flanking the opening of the anorectal canal becomes the anal fold. A new pair of swelling called the labioscrotal fold appears on either side of the urogenital fold, which finally fuse to form the scrotum in male and remains unfused to form the labia majora in female. This picture shows at the 6th week, there is a single cloacal membrane with cloacal fold on either side, which divided to form anterior urogenital fold and posterior anal fold at the 7th and late week. The external genitalia derived from a pair of labioscrotal fold, which fuses to form the scrotum in male and remains unfused to form the labia majora in female. A pair of urogenital fold, which fuses to form shaft of penis and penile urethra in male and remains unfused to form labia minora in female. And the anterior genital tubercle, which is responsible for the formation of glands of penis in male and clitoris in female. The development of urethra. The epithelium of most of the male urethra and the entire female urethra is derived from the endoderm of the urogenital sinus. In males, the distal part of the urethra in glands of the penis is derived from the solid cord of the ectodermal cell that grows inward from the tip of the glands and joins the rest of the spongy urethra. This slide is already discussed the fate of urogenital fold in male and female, the fate of genital tubercle in male and female, and labioscrotal fold in male and female. This picture shows the gradual development of the penile urethra by urethral groove after that formation of urethral plate, urethral fold, which finally fuses to form the penile urethra and shaft of penis in male, which is endodermal in origin, and epithelial invagination, which is ectodermal in origin to form the distal granular urethra. The elongating phallus is covered externally by the ectoderm that gives rise to the penile skin, whereas most of the substance of the penis is derived from the mesodermal cell, forming the corporal body's connective tissue and the dermis. In female, the genital tubercle bends inferiorly to form the clitoris, and urogenital fold remains separate to become the labia minora, as discussed, and the unfused labioscrotal fold from the labia majora, and the ostium of the urogenital membrane becomes the vestibule of the. This picture shows the fate of genital tubercle, urethral fold, and labioscrotal swelling, which is already discussed. Gonadal descent. Before the gonadal differentiation, the testis lies near the developing kidney, loosely held in place by two ligamentous structure. The dorsal ligament is cranial suspensory ligament, and the ventral ligament is the gubernaculum. Uh, uh, the testis is anchored near the inguinal region by enlargement of the gubernaculum and regression of the craniosuspensory ligament during the enlargement of the abdominal cavity. Descent of the testis through the inguinal canal into the scrotum usually begins during the 26th week, while simultaneously it is hollowed out by the evaginating peritoneal fold called the processus vaginalis. By 32 week, both the testes are present into the scrotum in most of the cases. Testicular descent through the inguinal canal into the scrotum is controlled by the androgens. Although intra-abdominal pressure may not be a factor during the initial trans-abdominal descent, it is thought to be important during the transit through the inguinal canal and the subsequent scrotal migration. In males, in presence of insulin-like 3-peptide, which is produced by the Leydig cell, it causes swelling and enlargement of the gubernaculum to pull the developing testis towards the inguinal region, whereas androgen will cause an involution of the suspensory ligament. In females, as CSL persists due to absence of androgen, and the gubernaculum remains thin due to absence of insulin-like peptide 3 activity, thereby keeping the ovary well within the pelvis. The undescended testis. The undescended testis is the most common anomaly in the male unit. It occurs in about 30% of the premature male and 3 to 5% in full-term male. During the first 3 months after birth, most undescended testis descends into the scrotum. If both the testes remains within or just outside the abdominal cavity, they fail to mature and sterility is a common condition. If this condition is uncorrected, these men have significantly higher risk of developing germ cell tumor, especially in case of abdominal cryptorchidism. Undescended testis may be abdominal cavity or anywhere along the usual path of descent of the testis, but they are usually in the inguinal canal. If after traversing the inguinal canal, the testis deviate from its usual path of the descent, the condition is called ectopic testis. This picture shows the possible position of the undescended testis and ectopic testis. The point to be noted that ectopic testis condition develop after traversing the inguinal canal. Put the video on that. Just yeah.
Yeah. Thank you, Mohammed. And I would request all of my residents to, if you have any query or thing that you haven't understood, because we will have some question answer session after this. So just for your benefit that you may answer the questions, I would just briefly summarize the whole thing. So embryology is very interesting topic if you actually read it, and it's important for the exam purposes. So at the 4th week, the intermediate mesoderm on the 2 sides of the aorta form urogenital ridge. And this urogenital ridge will ultimately develop into 2 parts, that is genital ridge and the nephrogenic cord or nephrogenic ridge. So the genital ridge will form the reproductive system, and the nephrogenic will form the kidneys and the urinary system, right? So when we talk about the nephrogenic cord, usually it divides into 3 parts. One is the pronephros in the cervical region, mesonephros in the thoracolumbar region, and metanephros in the sacral region. The pronephros usually involutes with time. The mesonephros will form the mesonephric tubules and mesonephric duct, right? So the mesonephric tubules actually forms the embryonic kidney. which actually is in the fetus for the initial few weeks till the metanephros takes over. And the mesonephric duct will give rise to the ureteric bud and other structures of the genital system. And particularly, and the metanephros, which again takes over to form the kidneys, metanephric blastema, and the ureteric bud, which is an outpouching from the mesonephric duct where it enters into the cloaca, right? And this ureteric bud will outpouch with some of these growth factors which are released from the metanephric blastema. And this ureteric bud will form the ureter, the renal pelvis, the major and minor calyces, and the collecting tubules, 1 to 3 million collecting tubules. And the metanephric blastema would form the glomeruli and the Bowman's capsule and the ultimate kidney. So this whole process is actually being governed by a number of factors. One is various genes, proteins, and hormones. So any kind of abnormality or mutation in the genes or a misstep in the whole cascade of this mechanism would result in various abnormalities, like absence or kind of a malrotation or malformation or duplicity, right? So some of these important factors, as we said, the genes are responsible, W2E1 and PAX1, PAX2, gene, etc. Then there are certain hormones like BMP4 and 7, bone morphometric protein for that molecular level. They are responsible for formation of kidneys, right? And then there are hormones like testosterone and estrogen and various other hormones which are responsible for formation of the secondary sexual characters and external genitalia. When we talk about the urinary bladder, cloaca, which actually ultimately divides into two, anterior part develops into urogenital sinus, and the posterior part develops into the rectum and anal canal. The urogenital sinus will form the bladder and the trigone, right? Not bladder, only the bladder, right? And the trigone is actually formed by the mesonephric duct, which also forms the ureter. And then the genital ridge, which actually forms the reproductive system, which is composed of two main tubes. One is the mesonephric duct, and the other is the paramesonephric. The mesonephric duct in males would form the various structures arising like beauty testes, vas deferens, and ejaculatory duct, etc. And the paramesonephric duct will form the female reproductive system, that the uterus, the vagina, and the fallopian tubes. And so this is again when the gonads, which is undifferentiated gonad, which develops at around again fifth week, which under the influence of the chromosomal sex, that SRY gene present on the Y chromosome will differentiate into testes. If the SRY gene is absent, it will not differentiate and it will develop into the ovary, right? So once the testis has developed, the Leydig cells produce testosterone, which leads to development of the external genitalia. And the Sertoli cells would produce a substance called Mullerian inhibiting substance, where the paramesonephric ducts or the Mullerian duct gets involuted, right? And if this MIS is not present, then the Mullerian duct will continue to be present. So this is overall, and the genital ridge, again, is divided into three parts. One is the genital tubercle, genital folds, and genital swellings. So genital tubercle ultimately forms the penis, and in females, clitoris. Genital folds will form the anterior part of the penis and the penile raphe, and in females, labia minora. And the genital swellings will form scrotum in males and labia majora in females, right? And the one more thing, that is the germ cells, which are actually present in the yolk sac, will migrate into the genital ridge at around fifth week, and then they will start then developing into the various gonads. So this is in nutshell about the whole embryology of the genitourinary system. And now we can go ahead to have some questions. So, most primitive renal structure in humans: pronephros, mesonephros, metanephros. Pronephros, right, which gets involuted. Mesonephros forms mesonephric tubules and mesonephric duct, and metanephros, which ultimately forms the kidney. So this is the which we have already explained. Choose the correct order of developmental stages. Metanephros, pronephros, mesonephros. C. Promesonephros, mesonephros, and metanephros. Right? So, yeah, I don't think there is any confusion here. It is the principal excretory organ during early embryonic life. This is called embryonic kidney. The mesonephric tubules, which forms the embryonic kidney, arises from mesonephros. Right. So this we have discussed. What type of tissue forms the loop of Henle? Metanephros. So the ureteric bud will ultimately form the ureter, the renal pelvis, the major calyces, minor calyces, and the collecting tubules. And the metanephric blastema will form the glomeruli, Bowman's capsule, and then the tubule will extend and then form all the tubules, that proximal convoluted tubule, loop of Henle, and the distal convoluted, right? So urinary bladder develops from which type of tissue? Mesodermal, ectodermal, endodermal. Pardon? Endodermal, urogenital sinus, right? The urothelial lining is done by endoderm, but the urogenital sinus is, I think it should be either urogenital sinus or the other structures. The ventral portion of the urogenital sinus forms the bladder, right? And the trigone is from mesonephric duct, right? The ventral portion of the urogenital sinus forms bladder and entire urethra of females, bladder and entire urethra of males, bladder only of males, urethra only. So in bladder and entire urethra of females, right? So it will form the bladder and the posterior urethra and the penile urethra, part of the penile urethra in males, not the entire urethra. The ventral portion of the urogenital sinus forms the proximal urethra of females, proximal urethra of males. So proximal urethra of males. So we have explained. The gubernaculum forms the round ligament, short ligament, ovarian ligament. Ovarian ligament. So the correct answer is ovarian ligament. The gubernaculum is a structure in the fetal development of both males and females. In males, it guides the descent of the testis into the scrotum. In females, it becomes the ovarian ligament, which attaches the ovary to the uterus. Actually, the testis is also attached to the anterior abdominal wall by this gubernaculum cord, which is actually responsible for, one of the factors responsible for the descent of the testis into the scrotum, right? Besides the raised intra-abdominal pressure and the hormone, right? The labia minora is formed from urethral folds. So the genital ridge divides into three. One is the genital tubercle, genital folds, and genital swellings. Genital tubercle forms the penis and clitoris. Genital folds will form the anterior part of the penis, penile raphe, and labia minora. And the genital swellings will form the labia majora and the scrotum. Okay, thank you. Thank you, everybody. So I would request now Somendra to, as a moderator of the session, to give his last comment, and then we will wind up. Thank you.
Thank you, Faisal, for such a nice presentation, and thank you, Shivam sir, for the briefing this topic concisely. And once again, thank you all resident and faculty member who might join us on Zoom meeting. This topic is purely theoretical, and you may get a question in the exam on the retrocable ureter, horseshoe kidney, and the urethra. So thank you once again, all of you.
Thank you, Somendra. Thank you once again, Faisal, for presenting us. Thanks to all the residents and faculty members and all those who might have joined us today on Zoom and YouTube. So thank you very much and have a good day.